So if you look at your screens, please remember yesterday we talked about the plateau, how you're always evaluating the axial view, how the anterolateral approach gives us access to most of the anterolateral side. So we have the anterolateral. We're gonna do the extended anterolateral after the anterolateral, and then we're gonna do the medial approach, and you're gonna see how much you can access through that. And then we're gonna flip and do the post-medial approach, and we're gonna get access to all the posteromedial surface up to the head of the fibula. And then we're gonna do the direct posterolateral approach. This is the sequence we're gonna do now, okay? So we're gonna do the anterolateral and then extended anterolateral now, but we need to do them in phases. So first one is just anterolateral. Do not expose more than that. So I'm gonna skip the medial to go to the anterolateral. You remember that you go midway laterally to the patella, you open up distal to the joint, the ITB, you're exposing the meniscus, you lift the meniscus up, submeniscal approach to get to the joint line, you're reflecting your extensors on the upper tibial surface, then you go into the ITB, you lift the meniscus up, and then you see the articular surface. This is the classic lateral approach. And this is what we're going to start with now. Do not do more than this. Then we're going to go later to the extended anterolateral. So stop at this stage. Okay, Dr. Nanu?
Okay, so as was mentioned in the first presentation, the important thing is patients come in different sizes. They can come with a big leg, they can come with a small leg, but the anatomical landmarks don't change. But you need to know where the bony points that are clearly identifiable are. So Professor Osama Farouk and I will be doing the two parts of this. For your safety and for the patient's safety, mark out the first line here, which is your anterior tibial crest. Your tibial tuberosity you've already marked from the first approach. Put one finger lateral to your tibial crest, and that will be the point of starting your standard anterolateral approach. So the biggest bump you can find posterolaterally here, feel it, all of you, feel it, that's your fibula head. And it is really important that you identify and mark it like I have here, because that is the point of attachment of the two heads of your biceps, which come at the back, and the fibula collateral ligament, which I have marked here, which goes across towards your lateral epicondyle region. What you cannot see and what you cannot feel is another very important structure, which is the popliteus tendon, which I have marked here. So that part, how to identify it, how to clear it, and how to put a rim plate without damaging these two vital structures is the second part of this dissection. So what we're going to do now is the first straightforward part, which is what most of you need to do for an anterolateral fracture. The extension, where you extend it, is only needed if you have a posterolateral fragment. Are we clear? Good. So you've made a decision when you're starting whether you need just an anterolateral approach or whether you may need to extend it posterolaterally to capture that posterolateral fragment, or if you think the fracture is going slightly more posterior than a true posterolateral fragment. Depending on that, your incision will change from this here to one that may go more posteriorly towards your fibula head. But we'll start with this, and then you can always curve it like this for the extension. All right? Patients in general prefer straight incision, so if you can make your decision before you start, you get a better looking scar rather than a curve, but it doesn't really matter. Happy? Good. Let's get started. Nurse Osama, can you pass me the knife? Thank you. I'll be the nurse for your part. Okay, so usually sharp dissection is the best way to go. So I'm making my incision towards Gerdy's tubercle, and I've marked here the joint line of the lateral femoral condyle, and for this part of the approach, I'm going to stop here. I need a pair of fine forceps, which is here. And you can see the crural fascia, which continues up here into the iliotibial band, which you can see the fibers sweeping down here. Can you see that? Okay? So there are two kinds of people. Those who believe that you open the fascia like this, blade's not very sharp. Okay, and then you lift it up and you peel your tissues. You can do it with either sharp dissection, or you can do it with the periosteal elevator like you saw the last time. So having done that, I'll use my periosteal elevator and I will move, and you see how beautiful tissues are. And you come straight down and there's nothing that you can damage here. But be careful about these muscles, because don't retract them forcibly, because if you do, they will swell up and you may get a compartment syndrome. So I can feel here again, I'll use my skin marker when I get in. As I go posteriorly, you can see the fibular head coming into view there, this white structure, and I'm aware that that is where I had marked it beforehand, and I know the fibular collateral ligament will be running here, so I'm not going to transgress that. But what I'm going to do is to open up in the line right up to here, which is as far as I need to go. I don't need to go any further if I'm just going to deal with an anterolateral fragment. And the next step is you take your extensor muscles off from the tibial condyle. You can use sharp dissection, which I think I prefer, or you can use an electrocautery. I don't have much of a choice at the moment. And you peel this back from Gerdy's tubercle. Right, use my periosteal elevator further. Where is the big one? Oh, never mind, we'll just use this. So you can see now that we have exposed enough. The rest of the plate you can slip in percutaneously here. You don't really need to do anything further. Thank you. Okay. So now I have reached the anterior limit of the fibula, which is fibula head, which is over here. And the next step is identifying where the joint is. So I have marked the joint, but in real life what I do is I use a needle. So we don't have a needle here at the moment. Yeah. So you identify where your joint is by using a needle into the joint here, right? And having identified that's where it is, you peel off your tissues anteriorly here. Okay, now we make our incision. You can see the bulge. Can you see the bulge of the synovium with its fluid that comes through from here? And again, you can confirm that you are in the joint. You can see the thing disappears. Sorry, this is my joint. Thing is moving, and you can see the joint fluid coming. So having identified that, you can then make your incision. Sorry, can you just move the camera back? I can't see. No, move it up. Thank you. You can then go underneath, lift up your meniscus. Do we have any sutures here? So you can see here, oh, right, sorry, okay. So you can see here, I'll just use this because we don't have sutures at the moment. So you can see inside the joint there. Yeah? So you just put sutures into the edge of the meniscus. You can go anteriorly as far as you wish. But posteriorly, remember, at this stage, just stop here. You only have one specimen, so we're going to do the second part to show how to get around the posterior edge. So do not divide your meniscotibial ligaments any further back, because if you do, you may damage the popliteus and you may damage the fibula collateral. So stop here, because this will actually give you, by applying a force in this direction, it will give you a pretty good view inside the joint, and you can see the anterior 3/4 of the joint from here to get your reduction. And usually you have a fracture of the lateral head coming down here. You can move the fragment out like a window, go inside, reduce under direct vision, put this back like a trapdoor, and fix it with K-wires. So can we just do this part, which is the smallest part of this approach, and then we'll take you back to how to get underneath the popliteus and the fibula collateral ligament to get into the posterolateral fragment that we were talking about yesterday. So can you do this? And we'll come back to you. Thank you.